So back to the adrenal glands, though, that's what we're really here to talk about. We've talked about adrenaline and noradrenaline, and we mentioned the fact that around the adrenal glands is another group of cells, and they make two very important hormones. So the first is called cortisol, and that's what we call a glucocorticoid, and that's a hormone that, in simple terms, is another stress hormone. It's a hormone that's involved in metabolism, it's involved in the control and regulation of your blood pressure, and it has a critical role in all of the cells in the body, important for immune system, etc. The other hormone that is very important and one must have is the hormone called aldosterone, and aldosterone is a hormone that we call a mineralocorticoid hormone, and this is a hormone that grabs back the salt that one's losing in the kidneys, and as it grabs back the salt, the water follows the salt, so it's important for holding on to salt and water, and therefore it's also important in regulating the blood pressure. Why would one become steroid dependent? Just going back a step. As a rule in the UK, the commonest reason that someone might need steroids permanently or semi-permanently would actually be because of medication. So steroids are used to dampen down inflammation, and they're used to treat lots of conditions from asthma to Crohn's disease to rheumatoid arthritis. And if one's on steroids taken as tablets or as injections for a long time, that switches off the normal controls over the adrenal glands and means that it can be hard to wake up the glands. So probably the commonest reason why people are on replacement is because they've previously had too much steroids on board. I think the second commonest reason would be when the pituitary gland, which controls the adrenal glands, fails to work. So if one has a tumour in the pituitary gland, for instance, and in the other condition, MEN1, that's one of the problems that one can get there. So both of those two causes are very different from the reason why one might need steroids in MEN2, and the reason for that is because the system that controls aldosterone is still intact. When one's lost one's adrenal glands, either through surgery, because one's had a pheochromocytoma on both sides and needed to remove both glands, or if one has a condition whereby one destroys the glands, and that's something called Addison's disease, you lose both the ability to make cortisol and the ability to make aldosterone. And that's a much more dangerous situation because you have a higher risk of having what we'll talk about as an Addisonian crisis because of the loss of ability to hang on to salt and water. So getting it right, getting cortisol right, it's going to be really important. And that's because too much is not good for you and causes increased appetite, increased weight gain, it causes infections, it causes an increase in your blood pressure, it can cause diabetes, it causes thin skin, it causes muscle wasting, bruising, and all of the negative things that go with that. So getting too much is not good in the long term. Getting too little is even worse though, because if one doesn't have enough, then initially one might get some abdominal pains and a bit of nausea, a bit of vomiting, a bit of dizziness, but with time one can get a seriously low blood pressure and a considerable and serious risk of death. And commoner than having both one's adrenals out is the condition of Addison's disease, where antibodies that should be fighting off infection have destroyed one's adrenal glands. And in that condition, it's thought that the chance of dying for someone of a given age is approximately double the chance of someone that doesn't have that condition. So it's a significant risk to one's overall health, and we're going to talk about why we think there's that doubling of risk and how to avoid it, essentially. Aldosterone, similar in terms of its nature. We've talked about the fact that it increases salt and water retention. If you do that on the long term, that will put your blood pressure up, so too much is not good. Too little will mean that you don't hang on to your salt and water and you'll therefore suffer from low blood pressure and dizziness and a risk of collapse, and again will contribute to that risk of of having a crisis. So replacing the cortisol, the main tablet that is used to replace cortisol is a tablet called hydrocortisone, which looks very, very similar to cortisol and is rapidly turned into cortisol as in the blood. We like it because it's easy to measure in the blood, and you measure it as cortisol in the blood, so one can check that someone's absorbing it by measuring the level half an hour after you've taken a dose. It also is good and bad, in brackets, because it lasts a short time in the blood, and I'll show you in a moment why that's relevant. It comes as in a dose form that means it's relatively easy to fine-tune and try and get right for an individual person in the same way we talked about with thyroxine. And the other important thing to talk about when talking about hydrocortisone is that any of you that are on hydrocortisone will have no doubt come across people, including doctors, including people that should know better, that say, oh my goodness, you're on long-term steroids, you're going to get thin bones, you're going to get all of the problems we talked about. And of course, that's not the aim of hydrocortisone replacement. The aim of hydrocortisone replacement is to get the physiological level to exactly where it should be and would have been before one's had one's adrenals removed. So one's not at risk, if the dose is right, of having all of those problems. So do put those people right. The disadvantage of it is the same as its advantage in that it lasts a relatively short time in the blood, so one processes it and gets rid of it relatively quickly, which means that if one's unwell, you can quite rapidly deplete your levels, and that can lead to the crisis and the serious problems that we talked about. So what this shows is what the normal levels are in the body, and what you can see is that as you wake up in the morning, your level of cortisol, which is on this side, this is the time from midnight to midnight, is highest as you get out of bed. So it's your get up and go hormone, and as you can see, in your sleep, its levels are undetectable, and then as things come to your body should be getting up and going to work. It might be slightly reluctant between up to about 6 or 7 o'clock, but then it's coming up and saying, okay, now we've got to get up there and get out. And then what happens during the day is essentially you get a gradual fall such that when it's time for sleep at midnight, the level should be undetectable again. And you can see that within the day, there's a little peak here at breakfast time, lunch and dinner, and that sort of fits in nicely with how most people would take their tablets. So one can give a bigger dose in the morning to make up for that bigger rise, and then smaller doses following on through the day. So a typical dose for replacement would be 20 milligrams, but that could be fine-tuned up or fine-tuned down depending on the individual. And it seems, for whatever reason, that the last dose in the day is probably slightly more effective in terms of raising the levels than this dose for reasons that aren't clear. And that just means that certainly I've got a lot of people that have reduced the dose in the evening to 2.5 milligrams, which is a real fiddle in terms of dividing your tablets up into quarters, but it does mean that you're not getting a high level at the time when one should be going to sleep. Similarly, if because there's a higher risk if one's had both one's adrenals removed, I think many people might be on 10 milligrams and 10 milligrams at that second point, depending on symptoms and how quickly one is prone to drop the levels and have a crisis. Aldosterone is a bit easier than hydrocortisone, and that's replaced with a tablet called Fludrocortisone. That can be given as a once or twice a day tablet, and the dose of that is typically 100 to 200 micrograms in a day. But again, that can be fine-tuned to a degree. The current advice for anyone that's on that is that it's recently been stored in the fridge, but there's actually a supply issue, and Flurinef has now been discontinued, which is I think that's permanent. So, and I think that's potentially an issue, because my understanding is that the cost of the generic fludrocortisone is much, much higher, and it may well be that there's reluctance to prescribe it outside hospital, but we haven't seen that yet. But I think that's something to discuss afterwards, perhaps. It's very important not to miss one's fludrocortisone, otherwise you'll waste the salts from the urine. And it's harder to judge the dose, but I would typically judge the dose based on symptoms. So if one's on too little, one might have some dizziness when you stand up. If one's on too much, you might get a bit of ankle swelling or high blood pressure. And there is a hormone we can measure called renin, which is the hormone that normally controls the aldosterone level. If that's very high, it would suggest that one's on too little, and likewise, if it's completely switched off, it might suggest one's on too much. An important point when talking about fludrocortisone is just to mention the fact that if one's on high-dose hydrocortisone, which we're talking about in a moment, hydrocortisone does have an effect an aldosterone-like effect. So one doesn't need one's fludrocortisone if one's on very high doses of hydrocortisone. So if one's nil by mouth for whatever reason, then if you're having injections of hydrocortisone, you don't need to worry about getting the fludrocortisone on board at the same time. Sick day rules, that's, I think, why I'm here. So we mentioned the fact that the risk of death without one's adrenals is probably double the background. And I think that's probably two reasons. One reason is that at the time when that figure was worked out, people were on bigger doses of steroids overall than they are now, and that probably meant that there were some of those harmful effects that we saw. So a typical dose might have been 40 to 50 milligrams of hydrocortisone rather than 20 milligrams of hydrocortisone, and no doubt that had some harmful effects in the past. But I think the biggest reason is probably reluctance by, sometimes due to people not understanding the need in times gone by, and also reluctance of medical staff to give hydrocortisone when it's strictly necessary. And I'm sure you've all got some horror stories to share about where that's happened, where you've certainly been the one that knows better than the person that you're trying to persuade. So what I would normally say is to try and give some examples. If one has a very mild illness, such as a cold, such as some emotional stress, perhaps an exam or something, then that's not normally a situation where one would need to increase one's levels. Again, all of these things are slightly open to question, and you can sort of check people's cortisol levels before they go into an exam and see that they're up a little bit, but they're not up very much. That's sort of where some of these rules come from, measuring people's levels and working out what happens. Certainly if one has what I've called a mild illness, perhaps a moderate to mild illness, then normally as part of the response to that illness, the stress response, one's cortisol levels goes up. So it's really important if one's unwell with, say, the flu or any cause of fever or a urine infection or something like that, that one doubles up one's dose of hydrocortisone as soon as one feels that one's unwell. And I think that's really important to do that during the course of the illness and for 24, 48 hours after that's resolved. So if one's got the flu, that's going to take 3 days to get through your system, say, and probably a couple of days on top to get completely better. And if one does that too late, you're going to take much longer to get over it. You're going to be sicker at the beginning. And if one does it, and if one stops it too early, then one's also going to have a bit of a knock-on effect, I think. So if the illness is severe, if you're vomiting and can't take your tablets, or if you've got really bad diarrhea, you're worried that you're not absorbing it, then that's the time to use the emergency injection. And I think Joe's armed with some oranges to make sure that everyone's comfortable with stabbing an orange shortly. The emergency injection is not there as a one-off treatment. The emergency injection is there to keep you safe until you've got medical help, and it will give you a 6-hour window to make sure that you've got medical advice. You might well feel better after you've had your emergency injection and think, oh, I don't need to go to hospital, I don't need to seek advice. Wrong decision. You feel better because the cortisol level is up and it will fall off again 4 or 5 hours later. So that is the window of opportunity to get some help. I put at the bottom as my reminder, surgery, procedures, separate issue. It's planned, hopefully. Sometimes it's not, but then it's an emergency situation and one has the injection. For a planned procedure, having a plan in place for what is required for one's hydrocortisone is going to be crucial, and getting your consultant to write a letter and support you with that is critical. If you're having a dental procedure, if you're having your tooth out under local anaesthetic, my advice normally would be, you don't need to particularly have an argument with a dentist if they don't want you to take more, is to take 20 milligrams instead of 10 milligrams in the morning before you go up there. If you don't do that and you have a reaction to the local anaesthetic and you vomit, then you won't be in a position to take that extra hydrocortisone that you need. So it's better just to take a 20 milligram dose. That will cover you safely. It's a local procedure. It doesn't need more than that. And to a certain extent, I would be happy to write that, but I would normally tell somebody, just do it. You're in control. So I would always ask in every clinic how many times someone's increased their hydrocortisone over the year. And if it's 1 to 3 times, I'd be fairly relaxed about that, as this is just my own view. If there's been no need to increase over a year, that might be because they've had a fighting fit year and be really good. But if it's every year, I've never increased it, I would start to be a bit worried that they're being a bit reserved and British about the whole thing and keeping their hydrocortisone for a rainy day. So I would just be trying to tease out whether or not they might be better taking some at times. And if it's many more times than 3 times, it may be because one's had lots of crashes, but it also could be because someone's taking them a bit too often, and that in the long run, as we've heard, might not be a good thing. Having said all of that, I would still say it's better to take than not to take, and if in doubt, take a dose and then get advice through whatever means one can, whether it's through a MEND, whether it's through your clinical nurse specialist or through your GP. A bit of housekeeping. What sort of things should everyone have? I think it's important that you and your families, and really families probably more because you know it, have the information leaflet and just understand about the need for taking that extra steroids. Hopefully everyone would have a steroid card, a medic alert, bracelet, necklace or equivalent, and then the all-important emergency pack, which we'll talk about shortly, Joe will take through. I think it's really helpful to have a travel letter, probably in your, somewhere at home as your armamentarium, which will do 2 things. It will state the medication so that if you go abroad and your bag's stolen or whatever, that you've got some proof, if you like, other than the medical alert system to say what you need, and also a travel letter to say that you need to carry your emergency injection with your needle on the plane and that you're not a terrorist. A little bit just about getting the dose right. We saw that the levels are highest as you wake up in the morning, so it's really important to take your hydrocortisone first thing. And by first thing, I don't mean with breakfast. I don't mean an hour after breakfast. I don't mean reading the leaflet and saying take with food. It means as you wake up, and that's if you press snooze like I do normally to drag out the time, then even better if you can take it with a sip of water, take your tablet, have 20 minutes snooze, and you'll be getting up with a level of get up and go that one would have had if we had your adrenals in place. So you can take it on an empty stomach and get it in your system as soon as possible. Typically, about 5 hours after that, that dose will have worn out. So 5 hours after that, which happens to be midday, 1 o'clock for most people probably, is the right time to take it. And if you're going to bed at a normal time, then probably taking it no later than 6 or 7 so that that levels out to your system by sleep time is the right time to take it. Lots of exceptions, and I think those probably need to be discussed individually. For people who work night shifts or something, that becomes really complicated to try and get it right. An overnight flight, things like that, it normally ends up meaning one's taking probably a bit more to cover it if it's a one-off. It needs some more serious thought if one's doing regular night shifts or something like that. I think that hopefully, I know you're going to throw things at me if I say it, hopefully most people that are on hydrocortisone are getting 3 monthly prescriptions, not every month, meaning that you can keep up to date with your supply. If you're not getting that, I think your GP should be written to and advised to make sure that you get 3 monthly prescriptions. I think that everybody should have some spare tablets locked away in different cupboards and things out of kids' reach, but within the areas where you might be able to find them if you can't find your normal tablets. And if one forgets to take tablets, goodness me, I certainly would, then there are lots of good smartphone apps and things that can help remind you. I think someone showed me one in clinic the other day where you actually have to take the pill on your smartphone and put it in your mouth. So you either have to lie to yourself really badly and then to finish off, last slide, other options. There are lots of other steroids out there, so occasionally people, for one reason or another, will suggest using prednisolone rather than hydrocortisone, or dexamethasone, for instance, and there are other steroids out there. Lots of you will have heard about or read about the new long-acting dual-phase hydrocortisone called Plenidrin, and we can talk about that later. And there's even some people that would advocate the use of a continuous circadian rhythm infusion, an infusion of hydrocortisone that adjusts through the day. So all of those are other options in particular circumstances. And then the last thing I've thrown down, just as a reminder, is DHEA. That's something else that could also be considered for some people. That's one of the other steroid hormones that the adrenal glands make. It's actually a weak male hormone. It's a hormone called an androgen. And for men, there's no real evidence that it helps men feel better. That's probably because they've got lots of testosterone from other sources. But in some female patients that have had both adrenals out or have Addison's disease, there's some evidence that some people feel better with a small supplement of DHEA. That's not something that's available on prescription, but it is one of these particularly American health supplements of aging, and it is fairly easily available, and sometimes I would recommend people give it a try and see whether or not it helps. That's my lot. I think I've caught up a little bit of time.